This is a diagnosing genetic disease tutorial presented by the SchrDbb reference ABC of Clinical Genetics by Helen Kingston. So, hello. So in this tutorial, we're going to study diagnosing genetic assessment. That is how to diagnose genetic disease. So now we need to know that what genetic. So we start with the genetic diagnosis. So the role of genetics is to establish an accurate diagnosis. We said that you have to diagnose the genetic disease. The first thing. The second thing is to know how to treat that particular genetic disease. But since treatment is difficult, you have to mainly know how to know the cause of that genetic disease in the family, and you have to know how to prevent the reoccurrence of that genetic diseases in the family. That all those set of questions can all those set of answers can help you to answer the different questions of the parents. So, in order for you to go into the diagnosis, you are going to start up with the history taking of a clinical genetic disorder, basically. So, the history taking, it has the same history taking like in medicine, but there are certain things that you are going to take particular attention, like the family history. So family history is going to be very important in this patient because you want to know if there is a family issue of that particular genetic disease in the family. Now there are certain things other in the history. You are the first thing, the presenting complaint of the parents. Example, it can be just a cleft on the lip, it can be different disorders. The presenting complaint. So we have other information to gather. So what are the parental ages? The maternal age is very important because Down syndrome increases the risk. It doubles in risk at the level of greater than 35 years of age. So and achondroplasia also double the risk when you have a father who is who is old age, like greater than 40 years of age. Achondroplasia, is it clear? So the parental age is very important. Second thing, you have the maternal health, like preeclampsia can give you congenital malformations. Maternal health, gestational diabetes can be very, very helpful. The pregnancy complications are very important. So exposure to potential teratogens like tetracycline, like thalidomide. So what are the fetal growth and movement, like the ultrasound? How was it? The antenatal history. So you have to know the ultrasound, what was there, what are the prenatal ultrasound scan. Is it clear? The mode of delivery. Is it cesarean section or and when was he delivered? Example, if the child is delivered premature, he may have certain congenital abnormalities. Is it clear? And previous, like a particular congenital abnormality you can have because the test descend later. You can have undescended testes. That's one congenital abnormality that the patient can have. So we have previous pregnancy outcomes also. So those are the different things that you must have inside the history of the patient. Now the next thing, you have the clinical examination of the patient. The clinical examination of a newborn goes from head to toe. It is topographical from head to toe. It is not systemic. So you go from the head, you examine the hairs, you examine the head, you take the anthropometric measurements, you examine the eyes and all that. So in order to know the particular things to ask for a particular patient, we are going to study it in a particular chapter. Example, for Down syndrome, you need to know that the patient is going to have a flat occiput, is going to have a wide nasal bridge, is going to have a macroglossia on the head. So all that are different. You have slanted eyes and you have low set ears. So those are the characteristics of Down syndrome that we are not going to speak about now. So after in the clinical examination, you need to know that the growth chart is also very important in the child because there are certain disorders like achondroplasia or hypochondroplasia that the child does not grow in length, or we have dwarfism, so that the child does not grow in length. So the growth chart is very important for age. So we have the mean age, so both for males and females. So you see that here is the normal growth chart. You see above here you have Marfan syndrome. Is it clear? So when the height is greater, because in Marfan syndrome you have a change in ratio of the upper limb segment and the lower limb segment. Is it clear? And see that the height of this patient is going to be high compared to the normal population. So you see, Marfan syndrome is going to be above the normal, above the 95th percentile, while achondroplasia is going to be below the 15th percentile. So we have the decrease here, or we have also dwarfism. So that is very important. Now the next thing you have also, this is a diagram showing the supraventricular aortic stenosis, as you can see here. So this is the aortic arc. So this is you can see this is the chest x-ray, the lateral view of a chest x-ray. Is it clear? So you see the aortic arc goes up, and then you have a stenosis here. And this stenosis can be seen in a child with Williams syndrome. We are going to see different syndromes later, so we are not going to speak about that specifically now. Now, you need to know that this chapter is mostly involved with the diagnosing clinical genetic diseases. So, to diagnose clinical genetic disease, you start from the history, then you go to your physical examination. After the physical examination, now you go to your different investigation method. As you have seen in the introduction, we have three main different investigation methods. We have cytogenetic investigation method, which consists of karyotyping, and we consist of karyotyping, fluorescent in situ hybridization, and also consist of computed array distribution. Now we also have the second one after cytogenetic method. We have molecular genetics, and the third one we have biochemical genetics. So all that is involved as a clinical in order to diagnose a particular genetic disease. After diagnosing a clinical genetic disease, the second thing to do now is to know what caused the clinical genetic disease and to prevent the reoccurrence of the clinical genetic disease. So to know what caused the clinical genetic disease, you are going to draw what is called a pedigree. A pedigree is just a tree in order to allocate the patient that were normal and the patient that were abnormal in the family tree. So we need to know that these are the different elements which are used inside the pedigree. So this is a male, this is a female, and this is an unknown sex. So if you have male, female, unknown sex, it's written like that. So when it is white like that, it means that they are unaffected. Now when it is dark, it means that they are clinically affected by the disease that the child is having. So that same disease that the child is having, they were affected with it. Now multiple traits, you need to know that as I've initially said, we have seen initially in the introduction that there were existing single gene diseases and there were multiple gene diseases, and we also have multifactorial disease. Multiple gene diseases are diseases whereby you have multiple genes that can be used in the formation of one disease. Example, there is a case of sensorineural deafness which is involved with multiple genes. Example, a patient may have a father may have a gene A of sensorineural deafness. So the father is having a gene A of sensorineural deafness, and the mother is having a gene B of sensorineural deafness. When the child is going to be AB, is going to have multiple traits for sensorineural deafness, but actually that child is not going to be having deafness. Why? Because there are autosomal recessive traits. Is it clear? I'm going to explain that more later. So these are multiple traits patients having multiple allele. So when they are saying, when I say trait, I just mean an allele. And what is an allele? An allele is a pair of elements that are going to give a particular gene. Is it clear? So a pair of different structures of elements that are going to give up a gene. A gene is a base of the clinical a base of what produces the phenotype of a patient is a gene, or the constituent of a patient is what is called a gene, while an allele is a pair that is going to produce that gene. So those are called different, also called the trait. Now the different one is the next one. This is a proband now. So a proband is the patient That is, so it's the patient and is the one who is consulting. It's called the proband. While this one who is not affected and is consulting is a consultant. Now, to say that somebody died, you just put an hour. This is an unaffected male that died, and it's an unaffected female that died. And you can also put the age of death here, 63 years. Then the next one, this is a carrier of autosomal disease, an X-linked autosomal disease. In order for you to show a carrier of a disease, you can just put a cross like that. You put here white, and here is not going to be white. So, but this is a carrier of an X-linked disease. Now, this is a pre-symptomatic carrier, but you don't know if the patient is having the genetic trait or not. Is it clear? So this is in order for you to show consanguinity. These are the children. So it just means that there is a female child and there is a male child. This one is an ongoing pregnancy. This is a miscarriage or termination. This is a twin pregnancy. So this one is dizygous, meaning that they are produced from two different sperms and two different ovum. And this one is monozygous, from one sperm and one ovum, from one zygote. Now this one is no children. So this is an example of a pedigree that was drawn. So this one means that the father is deceased, the father is dead. The mother, they were having two children, and then the male of that family was having now a child now with a carrier of X-linked disease, a mother carrier of X-linked disease, and the child that was produced now from that mother carrier is a male child and is the one consulting. So it's called the proband. Here now we had also another child in that family of the mother that was deceased. The brother of the mother was deceased. It means that he died and he was affected. Is it clear? So that's what just saw. And you see also the grandmother of the mother was a carrier of that disease. Is it clear? So this is how to show an X-linked disease. So from here you can think of an X-linked disease, a disease that is only mostly transferred from males, from mother to their male son, is mostly an X-linked disease. So you can think of an X-linked disease, or you can think of an X-linked disease. But if it's a disease transferred from the mother to all her children, it means that it is mostly a mitochondrial disease. But if you have a disease transferred from a mother to her male children, it's mostly an X-linked disease. So that's how the pedigree can help you. Now, consanguinity. So consanguinity is just the act of having children with one of their family members. So it is very important to know the aspect of consanguinity in order to prevent autosomal recessive disease, because you need to know that you need to know that among family members you share the same chromosome, you share the same genetic content with your family members. Is it clear? So if you have a child with your brother or your sister, therefore it is very likely that you are going to have, if there was an autosomal recessive gene in your family, then that autosomal recessive gene is going to express itself immediately. You are going to have a child. Is it clear? Example, if you had a gene of albinism, all of you in the family, so it means that immediately you are going to have a child. There is going to be a high risk for you to have an albinous child. Why? If you got married with another person that did not have the gene of albinism, since albinism gene is recessive, it's always going to be recessive all through your generation. Is it clear? So it is very important to know the relationship in order to prevent autosomal recessive genes to the different children. Is it clear? Now, this is now a table to help you know the genetic relationship with the different patients. We are different brothers and sisters in your family. Is it clear? Now, usually certain countries just tolerate marriage as from the third generation, and fourth generation. As from the third generation, they prevent, like certain culture, like in our context, you may even go up to the fifth generation before you get married. Is it clear? You mean at least the fifth generation before you get married. But certain other countries just tolerate the third generation. Even Asian countries may even tolerate second generation family issue. So now, if I say that there is a link between the genetic relationship is first generation, it means that it is parent to child and then siblings. It means that your genetic relationship is half. It means that what? It means that if the father is a carrier of an autosomal recessive disease, it means that all his children have a half probability of them to be carrier of that same recessive gene. Is it clear? If a father is a carrier of a recessive allele, it means that the probability for his children, for all his children, for the probability for one of his child, the probability for one of his child to have that for each of his child to have that allele is going to be half. Why? You share half genetic component. So if a father has a child with a child and then they have that are half shared, that the proportion that they share is half, it means that there's a very high probability that the child is going to come out with that disease if they share a same autosomal recessive trait, genetic disease trait. Now, second generation is between an uncle and a niece. That's the first. You have half siblings, like you have a father that get married. I don't like this one. The father, like a father that has a child with one mother, and then that same father has a child with another mother. Are you getting? So the children are produced from that have a second degree family history. Is it clear? That's second degree. So the children that are produced here are concerned. The children that are produced here have a second degree family issue. Now they said the next one now is double first cousin. So double first cousin. So double first cousin is what? You have child. So this child here, this male is related with this other female. They are brothers and sisters. And this other female is related to the other male. They are brothers and sisters. Now they are this male now get married to the brother of this one, and this brother get married to the sister of this one, and they have children. This one is a second degree family issue. Is it clear? Now third degree family issue. So cousins actually a third degree family issue. If you have the child of your aunt is your cousin, is going to be third degree family issue. So in Europe and other occidental countries, they may accept cousin as to get married. So sometimes they accept as from third generation family issue to that. So here in second generation is the disease risk is at 1/4, and then in third generation disease risk is at 1/8. Is it clear? Now also have uncle and niece. So when you have an uncle, and you have a niece, so this one is producing concern. So this mother was having a child with this father. They had a male child, and this other child here is here, and then all of them are great. So this mother now have another child here. This is third degree family issue. Now, and they share a genetic proportion of 1/8. Now fourth degree family issue is what? So you have one child. So these are brothers and sisters. This first one here is having a child, a male child, and then the next one is having a child, and then having a child again. So this is 1/16 proportion. Now, so this is now the fifth generation family issue. This may only be tolerated in our context Cameroon, but usually not. May only sometimes be tolerated. So example, when you have a grandfather and then you have brothers from grandfathers, so those brothers from grandfather, yes, say that one child here is here, and then there's another child produced. So when you are grandsons and grandson and granddaughters are fifth degree family issue, and they share a 132 genetic component. So the genetic component is 132 between both of them. So there's a very low risk of having genetic diseases. So it is accepted generally in Occidental country, but in our context in Africa, this can still be considered as an extended family. Okay. So from here we are finished now with genetic assessment. We continue now with genetic counseling. So thanks for your kind attention, and don't forget to like and subscribe for our channel. Thank you.